Hey everyone, this is Yoel Benroach. I'm a second year internal medicine resident at Beth Israel Deaconess, and I'm joined by Jason Matos. I'll let him introduce himself.
Hi again, Jason Matos, one of the cardiologists here at Beth Israel and proud Bloomgard firm chief.
So today we'll be covering ischemia in our third video lesson of the ECG course. So let's get started. Briefly, objectives. We want you to gain a basic understanding of the different changes seen on an ECG in MIs. We want you to identify ST elevation and depression patterns, as well as Q wave and T wave findings associated with ischemia. We'll do some practice at the end. Quickly go through an outlines. We'll go through definitions of injury versus ischemia versus infarction, the role of ECG in MI diagnosis. Then we'll start sort of from left to right on an EKG, starting with Q waves, talk about coronary territories a little bit, get to ST segments, elevations, depressions, and then MIs in left bundle branch blocks. We won't spend too much time on this. T waves, briefly mention Wellens syndrome, and then get to some practice EKGs at the end. All right, so starting with some definitions, and I want to include this because I think there's a lot of confusion with terminology and definitions, and even in the last 20, 30 years in the literature, there have been some discrepancies. But fortunately, the most recent universal definitions of MIs covers the differences between these three things. So starting with injury, myocardial injury is a troponin rise due to some insult. This can be from an ischemic insult, such as a STEMI, or it can be a non-ischemic insult, such as myocarditis or acute heart failure. You can imagine there's a lot of stress on the walls, a lot of ventricular remodeling with heart failure, and with that comes some troponemia, leak into the vessels. Then there's ischemia. This is your classic definition of ischemia, which is insufficient oxygen delivery, specifically to the myocardium in this case. And this can devolve into infarction, which we'll get into the definition, or it can be reversible ischemia. We also correlate this with ECG changes, new wall motion changes. If we have a new thrombus that we can actually visualize in the coronary arteries, that is technically also myocardial ischemia. Examples of this would be stable and unstable angina. And then we have infarction, which is when ischemia devolves into necrosis. Jason, do you have
Yeah,
anything else to add?
yeah, this is I think it's nice you put up this slide because it's really, and I think this is one of the better or best discriminators that I've seen. But the one thing is because you have ischemic in parentheses next to STEMI, which is correct. So I look at it as that you can have ischemia with injury and you can have injury with ischemia, but you could also have injury. You can also have injury without ischemia, right? So like myocarditis is injury without ischemia, and you can also have ischemia without injury, like stable angina, where maybe you're having ST depressions when you exercise, but you're having no injury. Injury typically being defined as the presence of troponins, just as is written here.
Great, thanks for clearing that up. Now just the role of the EKG in an acute MI. Just to point out, there's a lot of variability, inter-rater dependency. Of course, you get better with diagnosis with time and experience. And of course, everyone has unique anatomy, orientation of the heart, lead placement. People have different coronary anatomy. So just things to keep in mind. I think the takeaway here would be that EKGs can evolve with time, and it's very important to trend EKGs if you're concerned about anyone, especially if they have risk factors or the history is suspicious for ischemia. And someone once told me the best EKG interpreter in the room is the old EKG.
I totally agree. The only thing I would add is I would just have your sort of protocols that if ever you're thinking of checking a troponin, just get an ECG with that troponin. And I think that will provide you an adequate trend moving forward.
Good point. All right, we'll start with Q waves. Just a quick reminder, for the definition of Q wave, it's any negative deflection, so highlighted here in red, that precedes an R wave. And typically we go from left to right, as is demonstrated in this diagram. Um, Here it is on the EKG itself, highlighted in the red box. And Q waves can be physiologic. Normally see them in lateral leads, as you can imagine. If we have left to right depolarization across the septum, then, AVL, lead one, all our lateral leads, in theory, should have a small septal Q wave. And then in V1, since it's right-sided, we'll see small up deflection upwards, but this technically isn't a Q wave. So pathologic Q waves. These are usually seen from scar or area of necrosis, and it's because there's essentially no electrical activity in that area. We think of pathologic Q waves as being very deep, and this takes some practice, versus the physiologic Q waves I just pointed out. And here's some of the criteria. Wide Q waves are also atypical and considered pathologic. And here is an example of a deep Q wave being 4 millimeters deep, so well over one small box. This should definitely raise some concern if you see this. And this is unrelated, but we see a big old ST elevation associated here. And then a QS complex, if seen in two contiguous leads. QS complex essentially means there's just one large deflection downward. And Jason, do we always see Q waves with STEMIs? Do we see them with N STEMIs? Is there any sort of rule of thumb?
No, you could see them in either situation. I think more frequently or more often in STEMIs because there may be a larger amount of the myocardium that's impacted. Q waves can start to form in minutes to hours to days. So sometimes people say, oh, there's already Q waves, so it's too late. That's not necessarily the case, but to take someone to a lab for revascularization, particularly if there are ongoing symptoms. And then we'll talk about this a little later, but Q waves for a posterior infarction can manifest as small R waves in the early precordial leads like V1 and V2.
Okay. And then the absence of the small physiologic Q waves in V5, V6 are typically considered abnormal. So you should think of a bundle branch block versus a septal scar if you're missing those little Q waves less than a millimeter deep in your lateral lead. And as always, consider lead misplacements. If at all you're concerned, you can always get a repeat EKG. It's pretty low impact. All right, let's move on to the ST segment. So quick reminder on where we look for the ST segment and how it's defined. It's defined as the J point, which is where the QRS complex ends. So I'm pointing to it right here, all the way up until the T wave begins. So that's our ST segment. And just to segue into coronary distribution, because of course this is critical in understanding ST elevations and where you might have infarct and which territory. So as I said earlier, there can be variations, but in the vast majority of hearts, you have your left main proximally coming out of your aortic root. And then the LAD goes down the septal wall, and we have septal perforators and then diagonals coming off the LAD. Then for our left circumflex, this wraps around towards the back of the heart. Our right coronary artery, which is usually supplying our posterior descending artery, will correspond more towards for the inferior leads, whereas LAD is more the anterolateral leads and left circumflex, usually lateral leads. This is just a
Just can you go back one slide?
Yeah.
is weird that they put the AVR, I guess, kind of in the opposite position where the vector actually is. Like this is not really where AVR sits. It's almost opposite to that.
Oh, yeah.
It's usually over
Good
here. So
point.
it's
That
just kind of
is.
odd. Maybe they think that AVR is sort of reciprocal. So
Mhm.
anything in AVR, it's the opposite when it's over, you consider it there. I'm not sure.
Yeah, yeah, good point. That it's typically not where the AVR vector is. Um, and the way this manifests on an EKG, as I mentioned, usually are RCA, since it supplies the posterior wall of the heart, will usually manifest in the inferior leads, 2 through ABF, but there, 10% of the population can be left circumflex dominant, meaning the PDA is supplied by the left circ. Um, and then LAD is usually these anterolateral precordial leads, and the other lateral leads, 1 AVL, V5, V6, depending on where exactly along the LAD and left circumflex will show up in those leads.
Yeah, and I think you're referring to ST elevations here in terms of localizing the territory.
Correct.
Because just
Yes.
to say, these are big ST depressions in V1 and V2 here. So the deep ST depressions with the concurrent ST elevations over here and over here would actually suggest non-LAD territory, which we'll get to.
Hmm. All right, so ST elevations localize, as Jason just mentioned, whereas we'll get to ST depressions, but ST depressions typically don't localize to the coronary territory. We typically think of transmural infarction when we see ST elevations. And just to keep in mind, it's not just infarcts that cause ST elevations. I'm sure by now you've seen pericarditis. We can see bundle branch blocks, Brugadas, LV aneurysms, even status post cardioversion, PEs can also cause ST elevations. So don't anchor in on infarctions, but definitely can't miss those. And just to define, usually when we see ST elevations with infarcts, we want to see them in 2 contiguous leads in terms of territory. With V2, V3, we typically have a little bit higher of a threshold. It's not just one small box or 0.1 millivolts, but we won't get into too much detail. And then just to mention, if you see an ST elevation in AVR, that's pretty concerning because that can mean you have a left main stenosis or even triple vessel disease. If you see any ST elevations, always look for other signs of ischemia elsewhere on the EKG. And in terms of morphology, you may have heard the smiley face versus frowny face. So when it's concave, typically, not always, but typically it's not due to an infarction. It could be pericarditis, for example. And then when we see the frowny face morphology or convex, that is typically more strongly associated with infarction-related ST elevation.
Yeah, obviously there are other signs in pericarditis that we look for, notably PR depressions. So you look at the T to P segment as the baseline. And if you see the PR interval is lower than that T to P segment, that along with the concave ST elevations can be more specific for pericarditis. And also the most specific sign is you actually see those reciprocal, the PR elevations in AVR can be reassuring as well.
We have an example here. So if you want to take a moment to pause on your own and take a look through this EKG, and specifically hone in on the ST segments, as Jason just mentioned as well, if you want to look at the PR. And I'll just move along here. We see this more smiley face, concave ST elevation in various leads. And we see pretty diffuse ST elevations. So this is a pretty good example of acute pericarditis.
Yeah, actually, I appreciate the first smiley face is actually at the perfectly lined up with the ST segment. You actually colored it in perfectly with the blue, so that's impressive. And you can also see some PR elevation in AVR here. I think you can, I'll note it here. So if this is your T to P segment, your PR segment's up here. So there's some slight PR elevation, which also helps confirm the diagnosis.
Mhm. Yeah, great point. I guess all the first grade drawing along the line helped out here for me.
First one looked great.
Now, segueing into ST depressions, again, we look at the J points and then the segment between the J point and the start of the T wave. Usually with ST depressions, it's more subendocardial injury, but not always. And ST depressions do not localize, just to point that out. And usually it's the horizontal or downsloping ST depressions that we worry about a little bit more. And it seems like the criteria here are a little bit less, so just half of a small box, which I know can be really difficult to discern on an EKG, especially most of us who are not carrying calipers. I think a big takeaway here is if you see ST depressions, always check for reciprocal changes. Especially if you're worried about ischemia, look for ST elevations and other leads.
I think the horizontal or downsloping thing that you put here is really important. So I can think this is a great EKG, a great tracing to use as an example that you have. I would consider this horizontal to slightly upsloping because you
Mhm.
can see it's like horizontal and then slightly upslopes.
Right.
So a downsloping would kind of look more like this toward the T wave, and then
Mhm.
an early upsloping would get you to your T wave more like this. And this is horizontal to slightly upsloping. So would be not it, so the way I like to explain it, horizontal and downsloping, you should consider pathologic until proven otherwise. Upsloping, possibly pathologic, but high chance of being non-specific.
Okay. And if if you see ST depressions and they look pathologic and you're not seeing elevations anywhere else, you should always keep this in the back of your mind. This tends to be forgotten. Are these electrically silent lesions? And I'm sure we remember board questions where you want to get the posterior leads because you might have missed a sort of deep inferior or posterior lesion. And just a reminder, the posterior lead placement would essentially be under the scapula. And you just continue on from the precordial leads. And so it would go into V7, V8, V9. And I have an example on the next slide.
So this is what I was talking about with that other ECG you had with the different color diagrams of the territories.
Mm-hmm.
And you had that LAD where there was a deep ST depressions in V1, V2, V3 with inferior ST elevation. So that was an inferior posterior STEMI because of those ST depressions in V1 through V3.
Mm. So you can take a moment. We see some ST depressions in our precordial leads, but no really convincing ST elevations anywhere. So here are ST depressions. This is an example where the posterior leads were obtained V7, V8, and V9, and we see ST elevations. So this is an example of a posterior infarct.
I will say 3 and ABF look a little elevated in that first tracing.
3 and AVF.
It's 3 and ABF look maybe
Yeah,
mild.
it's hard to tell if it's a millimeter, but I agree.
Yeah, but it's again with the elevations in 3 more than 2 when those depressions that you noticed and what you're showing me V7, 8, 9 certainly would localize more to a posterior circumflex territory than RCA.
Hmm. All right, and then because we see a lot of bundle branch blocks in the hospital, essentially the diagnosis can be nuanced and tough. The most widely known criteria for approaching MIs in left bundle branch blocks specifically are the Scarbosa criteria. Just a note, Jason, can you apply the Scarbosa criteria to people who are V-paced?
I don't. I mean,
Okay.
you can always Not the Scarbo's criteria help a bit, but a lot of it's just comparing your tracing to prior, your prior ECG, just like you had mentioned earlier.
Hmm.
Sometimes in people who are not pacer dependent, I've had when I was a fellow attendings, the resident fellow attendings tell me to turn off the pacemaker and see what's underneath. It's not something I've really relied on in the past for other reasons. People can have ST changes just from going from pace to not pace.
Hmm.
So I don't really put too much stock in it.
Got it. That's very helpful. But yeah, I won't go into too much detail, but these are the criteria and has to do a lot with concordancy and discordancy.
Yeah, so I'll say that the two things I'll say about this is having a new left bundle branch block does not necessarily mean you're having a heart attack. It just makes it more challenging to interpret your EKG to determine whether you're having a heart attack. Um, and basically, with abnormal depolarization comes abnormal repolarization. So with bad LVH or big LVH and or a left bundle branch block, usually big R waves give you abnormal some ST depressions, and deep S waves give you ST elevations.
Hmm.
So the middle tracing here is a very classic finding you'd see in a left bundle branch block in V1, but with an overwhelming elevation that you can't ignore that's greater than 5 millimeters. So if this were, say, a 2 millimeter elevation, we would dismiss it, but because it's 5, it's a problem. This one the first one and the third one are these concordant changes, which you should not typically see with left bundle branch block, and therefore should raise your eyebrows for a concurrent ischemic process.
Thanks, Jason. That I'm very glad you brought up the left bundle branch in MI because I think there's a misconception that a new left bundle is always a STEMI. It sounds like not necessarily the case. And just to mention concordancy means if there's a negative deflection, the J point is also negative, meaning below the isoelectric line. So if our wave here is downward, um, sorry, S is downward, then our J point is also down below our isoelectric line. So these would be concordant changes. All right, we'll move on to the T wave. As we all know, this represents the repolarization of the myocardium. And typically we get positive T wave, so above the isoelectric line, following each QRS complex. And there are a few exceptions. Usually the more what we traditionally think of the right-sided leads won't follow that pattern. Here's just an example of a T wave. Now with ischemia, one of the most concerning findings are hyperacute T waves, which are seen down here because these can precede any other changes in a STEMI. If you see these very tall, broad, asymmetrically peaked T waves, and you're having a patient with chest pain or they have a lot of risk factors, you really want to get serial EKGs because these can be the first thing that pop up. And then we'll talk about T-wave inversions. Usually we think of pathologic T-wave inversions when we see them in two contiguous leads, and they have to be deeper than one small box or 1 millivolts. These do not localize to territory, just to say. And we typically see them as a marker of reperfusion, and they can be seen later in an NSTEMI. And here are some T-wave inversions in our precordial leads, V2, V3. We see they're deeper than one small box, so greater than 1 millivolt. Jason, do you have anything else to add about T-wave changes?
No, I think you're going to get into the next slide when we do think about when they could be a localizing sign.
Mm-hmm. And just to mention that there are non-ischemic conditions that can manifest as T-wave inversions. We have strain patterns, V-pacing, plenty of other things, cerebral T-waves. So don't anchor in on just ischemic changes with T-wave inversions. So let's talk about Wellens. this is usually a sign of critical stenosis of left main or the proximal LAD, so pretty significant lesion and concerning sign. What's really tricky is patients can sometimes be chest pain free, but what you'll see on the ECG is one of two patterns. There's a type A, which gives you a biphasic T wave, so it's usually up and then down. Here we have a T wave going up and then down in V2, V3. Or we can see deeply inverted symmetric T waves in the precordium, which is the other type of Wellens syndrome. These are pretty concerning since, you know, a proximal LAD or left main stenotic lesion can be quite detrimental.
Yeah, I'll say that the classic story is someone that's had chest pain, is maybe making some troponins and saying their chest pain is better, and they have an ECG that looks like this. And it's, you know, you really think about what's going on in the artery, and it's almost like you're subtotally occluded. Maybe you were, I almost think about it's a STEMI, but you missed the ST elevations while someone was on their way in, or while they were at home before they called 911. The ST elevations were there, now they're gone. But they can always come back. It could be sort of a subtotal occlusion that could re-occlude. You know, you can get deep T inversions like this across the precordium in other conditions, just like you said. The two big ones that happen acutely are, in addition to this, are cerebral T waves or stress cardiomyopathy. Those two things typically don't just localize to the early to mid precordial leads. So Wellens signs usually just in leads V1 through V4 or V2, V3 like you have. But usually the other two conditions spread out throughout the precordium and all toward the lateral leads as well.
Makes sense. And I read that about 75% of patients with Wellens sign on EKG have an acute MI within 1 or 2 weeks.
Yeah.
All right, let's get into some practice cases, and I encourage you to pause the video. Here I have the EKG sort of as enlarged as possible, so you can pause here, take a moment, and then when you're ready, we'll get started. So we have a 77-year-old woman, and just to continue our practice with approaching all ECGs systematically, we'll look at rates. And I'll fly through this just so we can spend a little more time on the ischemic changes. We have a rate of about 60. It's sinus, but based on the P waves. Our intervals are normal. Axis is left since we're up in 1, down in 2. QRS is less than 100 milliseconds. No SCT wave changes, but as I highlight here, we have some, what I mentioned as a QS wave in 3 AVF. We have deep Q waves in 2. We also have, it's hard to measure from this distance, but in V5, V6, we also have some pathologic Q waves. We see inverted T waves in 1, although can be pretty subtle, and AVL right here. So our impression here is sinus with pathologic Q waves in our inferior and lateral leads, consistent with inferolateral and STEMI, which is what was found.
The only two things I'll add is in V1 and V2, you can see some R wave there, which could indicate also a posterior, which is inferior lateral. The inferolateral wall is the posterior wall, so that makes sense. There are some small R waves in V1 and V2. And maybe there's some non-specific, maybe ST depression in 1 and AVL.
Right there. Okay, yeah, I see that. Yeah, this I think was called almost a reverse type R wave progression, because we typically don't see these R waves until later on V4. All right, second example, 68-year-old man. Take a chance to pause, and when you're ready, continue the video. So starting with rate, about 80 beats per minute, regular. We have sinus rhythm. P waves are up in 2. Our PR interval is normal. Axis is normal, up in 1, 2, AVF, QRS, normal. Now we do have some STT changes here, particularly in our lateral leads and our sort of septal precordial leads. So we have ST elevation in 1, AVL V2, V3, V4, V5. V6 is a little bit tougher to appreciate, but you definitely see them in the other precordial leads. V2, V3 are more significant or greater elevations, greater than 2 millimeters. We have slight ST depressions in our inferior leads to AVF, a little bit harder to appreciate in 2. And then T waves are sort of non-specific. So overall impression with this is we have sinus with ST elevations in 1, AVL, V2, V6, some pathologic Q waves in V2, V3, see these deep Q waves, all consistent with anterolateral STEMI, which was revealed with cardiac cath.
Yeah, I would say the the concavity, the concave down ST elevations, like the sad face, kind of make this more likely to be, injury and with the Q waves infarction. Something that would make this even more, that makes it even more specific for coronary are the, just like you wrote, the ST depressions inferiorly. Those are the classic reciprocal ST depressions, which you would not typically see with stress cardiomyopathy or pericarditis.
Hmm. Thank you. And third example, we have a 74-year-old woman. We can just assume all these patients are presenting with chest pain or nausea, dyspnea, diaphoresis. So you can pause and continue when you're ready. Starting with rates, 70 beats per minute, looks pretty regular. It's sinus based on our P waves here. PR interval is borderline, 200 milliseconds. We have left axis deviation, up in 1, down in 2. QRS is narrow. ST changes, you probably pointed out in 1, AVL, V4, V5, V6, pretty apparent ST elevations greater than 1 millimeter and greater than 2 millimeters in V2 and V3. No Q waves in this example. And hopefully you picked up on this. These T waves are quite big, broad, and asymmetric and seen throughout most of the precordium. So it's a scary sign. This would be called as sort of ST and T wave changes consistent with an anterolateral STEMI.
Your
Jason,
pathologic Q waves here, that you have it on the right, Q waves normal. So yeah, this is, you're sort of the timing of this, you're definitely catching it early because your elevations with the hyperacute T waves without Qs. So this woman came in right away.
Yeah, sorry, I gotta erase that here. You can ignore the impression. All right, and last example here, 70-year-old man, hypertension, troponins are up. You can pause and continue when you're ready. So, oh, sorry about that. We have the sneak peek impression here, but rates about 60, sinus, P waves up in 2, axis is normal. QRS is normal width, but we do sort of meet the criteria for LVH and AVL here, as it's greater than 11 millimeters, which would make sense if he has chronic hypertension. As far as ST changes go, this one may have been a little bit trickier, but wanted to point out AVR here has more of a frowny face or convex ST elevation. And we see a lot of ST depressions in 1, precordial leads, ST depressions. We see a couple in the inferior leads and 2 in AVF that are horizontal. This in 1, you see a good example of a downsloping ST depression.
Yeah, that's exactly what I was going to say. 1's a great example of downsloping, and then 2 is a great example of horizontal.
Yeah, and here's our frowny face in AVR. So as I mentioned earlier, ST elevation AVR with multiple reciprocal changes is really concerning for left main or triple vessel disease. And just to say, no major pathologic Q waves for T wave inversions here. So just to summarize, I think big three takeaways. I know it's a lot and there are volumes of textbooks on ECG changes in ischemia, but always look at prior ECGs if they're available. One single ECG is specific, but usually not sensitive. So always trend. Um, if you're worried about the troponin pattern, if you're worried about their history, if you're worried about their chest pain or risk factors. Uh, if at all you're concerned for ischemia, try to hone in on the Q waves, T waves, and ST segment. As always, be methodical and look at everything else, rate rhythm, etc. But this is where the most high yield changes will be in ischemia. And with ST elevations, always be on the lookout for other aberrancies.